Well, Masanga Hospital is very famous as a leprosy hospital, but at the moment it's more also open for different types of conditions and diseases. It's a district hospital, and I think in that sense it's attractive to many people living outside the big cities. It's in district hospital in the north part of Sierra Leone, and it serves mainly in Tonkolili district, which is a district with 500,000 inhabitants. But also you see many people are coming from outside this district. That's one part, so we are having the healthcare, but we're also very much involved in training programs because, well, we believe that's a sustainable way of giving healthcare to the country. So there's a college, a nursing college, but we also have, and I think this is also a very promising project, we have a surgical training program where community health officers, which are non-physicians, they had a training within the country, are trained to do certain procedures in the surgical field. So they are trained to do cesarean sections or hernia repairs, things which actually in the West countries maybe would be done by a surgeon, but simply there are not enough surgeons in the country. So we are filling and stepping in the gap, and with also collaboration with the government, providing this kind of services. So you can say it's task shifting, bringing resources, human resources, to those places where healthcare workers are most needed. And I think that's yeah, quite revolutionary. It's a very promising thing there. Yeah, that's the sad thing. It's not only affecting Masanga, but this Ebola outbreak, of course, we all know about it, is really affecting Masanga. In such a point that, well, we were there sent by a organization that they said, oh, this is not safe enough. Not only because of we didn't have enough personal equipment to protect ourselves, but also the social unrest, well, flying companies shutting down. So the tension in the country went up, and also the atmosphere changed a bit. And well, of course, this is very dramatic for the country, which is already really at the bottom of the Human Development Index, trying to, well, recover after this 10-year civil war, and now getting this fall back again with a major epidemic within the country. Yeah, it's very sad. We had the news that one of them, he was finished actually in Masanga. His name is Joseph, and he was a very good student, and we were happy to have him going further in the program. So he was now in a partner hospital in a big city close by, Makeni. Well, not that much now in our responsibility anymore, because this other partner hospital was taking over some part of the training. And we had the news last or 2 weeks ago that he got signs and symptoms of Ebola. We didn't know at that time yet because he wasn't tested, but he got also positive tests for other common diseases there, like malaria and I think even typhoid. So you could say maybe it was from that conditions, but he even got worse and worse. And at the end, well, I think 2 days after he unfortunately died, we also got the result back that he has Ebola, and that gave a big shock in the whole program.
Because how many students are in the training program?
27, yeah, 27. So it's not a big group, but they're quite connected, and well, for them it was a big shock as well. And I unfortunately I have to say that now, last week we heard that his father, his younger brother, and even his wife got infected, and his father and brother already passed away as well. So you see a big impact on the family scale. Well, because of the decision of the international board to withdraw us, it's not me only, but also my colleague Jurre van Kesteren. We have no doctors there at the moment, which is having, of course, a big impact on the possibilities and the admissions. So because of this decision, I believe that there will not be much new patients coming. So the risk of attracting Ebola in Masanga is really, really small. But of course, people in Masanga, they have their family members or their relatives living in other places as well. And we have quite some messages that people are also in the family bonds are getting infected. Yeah.
When do you expect to be able to return to Masanga?
This is a very good question and a very difficult question. We have been discussing it many, many times. What are the criteria? When is it safe enough? When can you say, oh, we should go? I think, well, we see the trend is not good. It's only getting worse now. The good thing is that we have got some donations already from protective for protective equipment, and some have arrived even now. So that part is now a little bit more secured. Yeah, well, it's difficult from a distance to say, okay, this is what you can do. Many things you have to be done in the country. What I think is one of the things, of course, is that we support as much as we can organizations which are involved in these countries, organizations or governments. And I think what you are doing as ADRA, you are also, I believe, in Liberia. Shipments have been going there, and now Sierra Leone is also getting much help of ADRA. So I think via these kind of channels, using the existing organizations, strengthening the healthcare systems, it seems like big words now, but I think it's also sometimes basically trying to support them, giving money, or in that way trying to send what is needed, equipment. You cannot do much like sensitizations because those things have to be happening over there. Yeah.
Okay. We have 95 staff, and that is medical staff and also auxiliary staff. And if we look at medical staff, we have two doctors. This is Bart Waalewijn and myself. Then we have 2 clinical health officers. These are trained in Sierra Leone and they see patients by themselves. Then we have 3 to 6 surgical training students, which are clinical health officers that are being trained to become clinical health officers with surgical experience. Then we only have 1 matron in the whole hospital, and we have 2 official nurses, 2 state-enrolled clinical health nurses, and we have 40 nurse aides. And these nurse aides are trained by ourselves. But we only have 2 nurses, but we have over 100 beds. So you can imagine that there's a big imbalance in the amount of beds that we have and the amount of nurses that we have in our hospital.
When did you first learn about this new Ebola virus that was going to be a threat?
It's already quite a long time ago. It was I remember it very well. It was the 22nd of March, it was a Saturday night. And we received an email from MSF. Be aware, there might be an Ebola outbreak in Guinea, not far away from you. And it was exactly the same evening that we just admitted a patient from Guinea ourselves. And that patient passed away on Sunday, the 23rd. And that was directly a suspected death. It was a patient that had a lot of comorbidity. It was a patient with HIV, with TB. But when he passed away, we received reports from the nurses that he passed away with blood loss from his mouth and blood loss from his nose. Unfortunately, the body was already taken away by family members before I could see it myself. But we have been in contact with the patient a lot during the admission. And we tried to look up the guidelines for what is the case definition of a suspected case or a suspected death. And this patient directly fitted the case definition. So from the moment that we received the email from MSF, 1 day later we already had our first suspected case. The reason that we are here today exactly is because of a meeting that we are having with King's College. Tonight there's a meeting to discuss what should the UK do and what should Holland do in order to be prepared, in order to support the people in Sierra Leone, and especially to support one of the hospitals in Freetown, Connaught Hospital. That was the initial reason to come to London first. and because we are also here because of ADRA, because of the huge support we receive from you. And we try to make a combination of both meetings at the same time. And that's the reason why we are here now. Yeah.
How important is the support that ADRA is giving you now? You know, we're talking about fencing, the water, the electricity. How important is that for Masanga?
I think it's very, very important. And yeah, it cannot be underestimated how important it is. It is one of the reasons why we are not there at the moment, I believe. We looked what are the problems, why do we need to go away, and one of the problems was we couldn't protect ourselves, we couldn't stay there any longer because there was no fencing around the hospital. So if social unrest would increase and if people would come to the hospital because of anger, there would be no way to protect ourselves. And especially on the long haul, this whole support from ADRA is very important to increase the level of hygiene in hospital, and hygiene can be created by having running water available continuously and by having power all the time. And these are two things that we are already working on for such a long time. But you need a big investment to have it done properly. And at the moment it was done just by every time a little bit repair, a little bit work, a little bit repair, a little bit work. And you didn't get the final result done. And we were looking for a big support. And we are very pleased and very happy with the support from ADRA to have a increase, like a big increase of money, in order to finalize these projects. Because these projects are already planned for a long time, but we were never able to finalize them. And with this support, we will be. I think it is. It is like a global problem, but it's not as a threat as in Western Africa. It will not spread like this in the UK. It will not spread like this in Holland or the States. As soon as you have one confirmed case in London, for example, or in Amsterdam or New York, we have very strict and very good isolation procedures. So the chance that that person will infect another person, that you have the human-to-human transmission in the Western world, that is not very, very likely. But it is a global problem if you look at the amount of people that are involved, and we cannot neglect that area. We cannot just say, oh, it's only in Western Africa, they should just solve it themselves. And the whole country is going down. It's not only on people that are dying, but the whole infrastructure is breaking down, the economy is breaking down. It might create social unrest, it might create instability of three countries that are already very, very fragile before the outbreak. So it might be dangerous for the whole region. That might export to other countries as well. So I do believe it's a global problem, and I don't think that Ebola will spread to Western countries like it spreads in these countries because of the different society and also the different traditions that we have. But yeah, it's more on a social level and on a human level that it is a global problem. Yeah, I think they are at risk. It is, you should always see if it's an acceptable risk or an unacceptable risk or a calculated risk. I think it's a calculated risk. That's if you look at what happens now, the amount of healthcare workers that are involved. Some healthcare workers they attract the virus because they see a patient while they're not being dressed up. So they maybe see a patient in the community, or they maybe see a patient that is admitted to the ward, and then that moment they attract the virus. But there also most likely are healthcare workers that attract the virus while they dress down their PPE, their personal protective equipment. It's not very, very difficult to do, but there are like 14 different steps that you have to take, and you have to do it in the right order, and you should be very careful that you don't contaminate yourself with your dirty gloves, that you don't take off your mask in a wrong way, for example. So if you follow these guidelines very, very strict, and that's something, for example, that's done by MSF, they have somebody like a buddy who's watching the person who's taking off the PPE and who's checking it continuously, then you can limit the risk. But as soon as you travel to a region where there's an unprecedented Ebola outbreak, I do believe that you increase your risk compared to the risk that you have, of course, back home in Canada, because there's no risk. So it is a slightly increase of the risk, but if you take all the precautions, and if you take all the measurements, you can decrease the risk to an acceptable risk. But I think it's very naive to believe that there will be no more healthcare worker being affected. Yeah, actually we are, because we left the beginning of August. We had to leave because of the situation, how it was. And I just packed my bag, like some clothes, and I left most of my stuff there, and I expected to be back at the end of August, beginning of September. Unfortunately, the whole situation is deteriorating. It's getting worse. It's not getting better at all. And our hospitals at the moment is not ready to receive us at the moment. We cannot go back and just open and just see patients on a normal base. This is really something for very big partners that have to be there, that have to set up the treatment centers. And we are just too small. We are 100 beds, 2 doctors, 2 nurses. We can go there, of course, but then the chance that we get infected ourselves is very, very high. But we would really like to go back, especially to coordinate the funding and the help from ADRA, because there's now money available for the hospital, but it should be coordinated as well. And there should be people on the ground to work on the fans, to work on the water supplies, to work on the solar system. So that would be a reason for us to go back. Maybe we would not directly start with clinical activities. We would not see directly all the patients in the hospital, but we would go back for the coordination of the funding that we received through ADRA.
And then slowly plan to reopen.
Yeah, of course, of course. As soon as we have the support from our international board and we have the support from the district, we would like to reopen. But it's not a decision that's only being made by Bart and by me. As a clinician, you want to be open, you want to see a patient. And that is something that's very strong. It's like a strong feeling inside of you. But sometimes it's also good that you have somebody behind you that is pulling you a little bit back. And at the moment when we had to leave in the beginning of August, I think both of us were very frustrated that we had to go. And now how we see that, how it evolved and how it got worse, I think it was a good decision by then for us to go back temporarily, to be in Holland, to do fundraising, to try to get attention for the project, to speak with people, to go to a lecture. We've been to Copenhagen to teach students there on Ebola. We did a lecture. We will do a lecture in Holland at the Royal Tropical Institute this month. And now we're here in London to speak with King. So we try to use our time in the best way possible. But in the end, we are taught to be a clinician and not to be a spokesperson, because as soon as we can go back, we would like to go back. Yeah.